Today's topic is ulcerative and vesicular and bullous lesion. First of all, classification. Classification according to the nature of the ulcer. It can be multiple ulcer or single ulcer. Multiple ulcer is further divided into two: the patient with the acute multiple ulcer and patient with the chronic multiple ulcer. Patient with the acute multiple ulcer include primary herpes simplex virus infection, Coxsackie virus infection, varicella zoster infection, erythema multiforme, Stevenson-Johnson syndrome, and toxic epidermal necrolysis, contact allergic stomatitis, oral ulcer secondary to cancer chemotherapy, and acute necrotizing ulcerative gingivitis. And patients with chronic multiple ulcers include pemphigus vulgaris, bullous pemphigoid, mucous membrane pemphigoid, linear IgA disease, epidermolysis bullosa acquisita. The patient with recurring oral ulcer and single ulcer include recurrent aphthous stomatitis, Bichard syndrome, and herpes labialis. And the patient with single ulcer include deep fungal infection, malignant ulcer, and traumatic ulcer. These are single ulcers. First is single ulcers, which include recurrent aphthous stomatitis. Recurrent aphthous ulceration is an inflammatory condition characterized by painful recurrent single or multiple ulceration of the oral mucosa. The term aphtha is derived from Greek word aphtha, which means ulceration, also called canker sores. The source is a basic term meaning painful and sensitive wound. Predisposing factors associated with recurrent aphthous stomatitis are local factors that include microbial factors. Local factors include trauma. Microbial factors are bacterial and viral. Bacterial include streptococcal and viral include varicella zoster or cytomegalovirus. Systemic factors include stress, Crohn's disease, celiac disease, ulcerative colitis, HIV infection, psychological imbalance, menstrual cycle, syndromes like Magic syndrome, Bichard's disease, Reiter syndrome, Sweet syndrome, and PFA-PA syndrome. Other uh, other predisposing factors include nutritional factors like iron, folic acid, or zinc deficiency, or vitamin B1, B2, B6, B12 deficiency. Allergic factors like food allergy and drug allergy. Autoimmune is questionable pathogenesis. Now these are the predisposing factors. Now the pathogenesis of recurrent aphthous stomatitis. The pathogenesis of recurrent aphthous stomatitis involve a predominantly cell-mediated immune response in which tumor necrotic factor alpha play a major role. Consists of three phases. Phase 1 is pre-ulcerative phase, phase 2 is ulcerative phase, and phase 3 is healing phase. Lymphocytes cell infiltrate in the epithelium causing erythema. That is phase 1, pre-ulcerative stage, which is followed by a localized papule surrounded by a reactive erythematous hollow due to inflammatory reaction, and the painful papule then ulcerate, and this phase is ulcerative phase, and the pseudomembrane cover the ulcer, which is infiltrated mainly by neutrophil and lymphocyte and plasma cell. And finally there is a healing with epithelial regeneration. This is the phase 3, that is a healing phase. Now the classical subtypes. Now the subtypes based on the nature of reoccurrence is a simple apoptosis and complex apoptosis. Simple apoptosis is here is a reoccurrence occur 2 to 4 times a year, and complex apoptosis disease activity is almost continuous throughout the year with newer lesion developing as older lesion heals, and usually complex apoptosis is associated with systemic disease. Second subtype is classification based on the frequency of recurrence. Type A, recurrent aphthous stomatitis episode lasting a few days with tolerable pain and few occurrences a year. The painful recurrent aphthous stomatitis lasting 3 to 10 days with recurrence every month. Type C, chronic painful course with disease activity almost continuous throughout the year. Now, the recurrent aphthous stomatitis has three main presentation, that is minor, major, and herpetiform ulcers. These are the minor, major, and herpetiform. Other names of major ulcer is periadenitis mucosa, necrotica recurrens, Sutton's disease, and mucous scarring aphtha. Minor having a size of less than 0.5 centimeter, major having a size of greater than 1 centimeter, and herpetiform having a size of less than 0.5 centimeter. All these have a shape of oval. These are all are oval in shape. Number. Now minor is 1 to 10 in number, major is 1 to 4 in number, and herpetiform is 10 to 100 in number. Location. Minor aphthous ulcer is always on the non-keratinized mucosa, major on the non-keratinized mucosa, and herpetiform any intraoral site can occur on the any intraoral site, and healing 10 to 14 days without scarring, and major may persist for up to 6 weeks and often heal with scarring, and herpetiform 10 to 14 days without scarring. Now the clinical features of recurrent aphthous stomatitis are clinical features are similar in all subtypes. It is most common in female at the second decade of life, and it is painful recurrent ulcer. Patient may have prodromal symptoms of tingling or burning before the appearance of the lesion, and the individual lesions are round, symmetric, shallow, with no tissue tag. Tissue tag is suggestive of traumatic ulcer. In aphthous, recurrent aphthous stomatitis, there is no tissue tag is present, and floor is covered by gray-white pseudomembrane, which is called yellowish slough, and it is surrounded by erythematous hollow. And progression of the disease, that is development of erythematous papule that ulcerate, and other features based on different forms are this is the erythematous papule seen with burning sensation. This is the pre-ulcerative phase. This is the pre-ulcerative phase of aphthous ulcer, and same erythematous area converted to aphthous ulceration here. This is the erythematous papule seen with burning sensation. This is the pre-ulcerative phase of aphthous ulcer, and same erythematous area is converted to aphthous ulceration. These are the different type of aphthas. This is the this is the minor aphtha, which is less than 0.5, which is less than 0.5 centimeters, and this is the major aphthas. This is major aphthas which is greater than 1 centimeter, and this is herpetiform. This is herpetiform, which is also less than 0.5 centimeter, 0.5 centimeter, but this is 10 to 100 in number, and major is 1 to 4 in number, and minor form is 1 to 10 in number. Now the aphthous ulcer of different location. Aphthous ulcer of different location. This is present on the aphthous ulceration of the palate, This is aphthous ulceration of the gingiva and the frenum. This is the aphthous ulcer of tip of the tongue, and this is aphthous ulcer on the ventral surface of the tongue. Now, the syndrome associated with aphtha or aphthous-like lesions. Syndrome associated is Ritter syndrome, which is a tetrad of non-gonococcal urethritis, arthritis, conjunctivitis, and mucogingival lesion. And the Behcet syndrome, which include recurrent oral ulceration at least 3 times in a 12-month period, and recurrent genital ulcer, eye lesions, and positive pathology test. Po- uh, Positive pathology test is present in only Behcet syndrome and it is absent in recurrent aphthous ulceration. Magic syndrome, which include mouth and genital ulcers with inflamed cartilage, and Sweet syndrome, which include recurrent oral ulceration, pyrexia, thrombophlebitis, and cutaneous lesion, and PFA-PA syndrome that include periodic fever, recurrent aphthous, pharyngitis, and cervical adenitis. Now, the differential diagnosis for single aphthous ulcer, the differential diagnosis are traumatic ulcer, tuberculous ulcer, and syphilitic ulcer. Other single ulcer like malignant and defungal, which are larger in size, and so cannot put in the differential diagnosis of this lesion. For multiple aphthous ulcer, differential diagnosis is primary herpetic gingivostomatitis, allergic stomatitis, erythema multiforme, benign mucous membrane pepicoid, pepicus, and neutropenic ulcer. And the investigation. The most common part is to find the exact cause of the aphtha, as many times patients come complaining reoccurring nature of this in spite of treating it with many modality or many doctors. Thus, most common thing is to rule out all precipitating factors like nutritional deficiency, advise vitamin B12, iron, and folate, any systemic disorder like complete blood count for anemic, endoscopy for gastritis, pathology test for Behcet syndrome, psychological evaluation for stress. Third is the exfoliative cytology or cytosmear can be done to rule out other ulcer. Now, the pathology test, which is test for Behcet syndrome. Pathology test is an easy to perform skin or mucosal test to look for pathology phenomenon. Pathology phenomenon is defined as a state of altered tissue reactivity that occur in response to minor trauma. It is seen in Behcet syndrome, and mechanism of pathology test is skin injury caused by needle prick apparently trigger a cutaneous inflammatory response, non-specific hypersensitivity reaction, which is much more prominent and extensive than that seen in the normal skin. Now it suggests an increase or aberrant release of cytokines. Now, the difference between herpes infection and recurrent aphthous ulceration. Etiology of herpes infection is herpes simplex virus 1, whereas recurrent aphthous stomatitis having a immune dysfunction. Other triggering factors of herpes is stress, trauma, UV light, depressed immunity, and recurrent aphthous stomatitis has stress, trauma, diet, hormone, depressed immunity. Prodromal symptoms here are fever, burning, irritability present, whereas there is a in recurrent aphthous stomatitis there is a little prodromal, only burning sensation of the area of future ulcer. Site is of recurrent of herpes infection is keratinized mucosa, mainly gingiva, marginal gingiva, hard palate, vermilion borders, whereas Recurrent aphthous stomatitis always occur on the non-keratinized mucosa like buccal mucosa, tongue, oropharynx, floor of the mouth. Marginal gingiva is not involved. Now the clinical features. Prodromal symptoms vesicle precede the ulceration and multiple confluent ulcer. Where in recurrent aphthous stomatitis there is no vesicle and single oval ulcer is present. Appearance of primary lesion is vesicle in herpes infection, and recurrent aphthous stomatitis has ulcers. Appearance of mature lesion. Herpes shallow punctate lesion with erythematous area is present, which is asymmetric in nature, and recurrent aphthous stomatitis has symmetric deeper than herpes with erythematous hollow. In gingival involvement, multiple single ulcer involving marginal gingiva, often in recurrent aphthous stomatitis, often have a single ulcer involving the attached gingiva. Number, it is few in number, whereas the recurrent aphthous only 1 to few in number. Site of occurrence at the same area, at different area or site. Pathergy test. It suggested increase or aberrant release of cytokine resulting in perivascular infiltration. Type of pathergy test. There are two type of pathergy test: skin pathergy test and mucosal pathergy test. Skin pathergy test. The procedure is performed on the hairless part of the volar forearm. Ideally, the skin should not be cleaned with disinfectant, and the blunt needle is inserted carefully, bevel up at an angle of 30 degrees to the skin into the dermis at the depth of 1.5 to 2 mm or 45 degree to the depth of 3 to 5 mm. The bevel should be obscured beneath the epidermis, withdrawn with a twisting movement. Reading are taken after 48 hours, and the test is considered positive if the erythematous papule, which is greater than 2 mm in diameter, is observed, and a more strongly positive reaction is reported based on the presence of pustule developing at the prick site. In case if 4 prick are done, then the test is considered positive if papule seen in at least 2 needle insertion and out of 4 prick, or pustule seen in at least 1 needle insertion. Now the oral pathergy test. In oral pathergy test, prick the mucous membrane of the lower lip to the submucosa using a 20 gauge blunt disposable needle, and reading are taken after 48 hours, and test is considered positive if pustule or ulcer is seen in that area. In this figure, epidermis, which is 0.1 mm, and dermis, which is 3 mm, and then the presence of hypodermis. Needle is inserted at the angulation of 30 degree um, into the 30 degree into the dermis at the depth of 1.5 to 2 mm. Now the oral pathergy test. The mucous membrane of the lower lip is pricked using 20 gauge blunt disposable needle, and reading taken after 48 hours show a ulcer. This is the positive pathergy test. And this is the oral pathergy test, in which the mucous membrane of the lower lip is pricked using 20 gauge blunt disposable needle, and the reading taken after 48 hours show an erythematous area. This is the negative pathergy test. Now the management part. Type A, that is minor form occurring every time or with very few reoccurrence. Minor form of aphthous ulcer has a treatment. Treatment include avoidance. First is the avoidance of the stimulus like stress, and certain foods should be avoided as they appear to trigger eruption of new aphtha or prolong the course of the lesion. These food are hard, acidic, salty, spicy, Nuts, chocolates, citrus fruit, alcoholic or carbonated drinks should be avoided. Treatment of anemia, if present, refer to the physician. Local analgesic like benzocaine or lidocaine gel applied 3 to 4 times a day. Tablet vitamin B12 with folate or tab B folate twice daily for 7 days. Antiseptic mouthwash like ben, benzdiamine hydrochloride 3 to 4 times a day. And topical application of drug like 5% amlexanox applied 3 to 4 times a day. Amlexanox is anti-inflammatory, anti-allergic and immunomodulator drug which inhibit inflammation by inhibiting the release of histamine and leukotrienes, etc. Now the type 2 minor form, that is painful occurring, very frequently occurring minor ulcer. Follow the treatment option given in type A. If it is not treatable with the above mentioned drug, then advise the topical steroid. Apply 3 to 4 times a day, which include clobetasol ointment 0.05% or triamcinolone acetonide 0.1%. Apply 3-4 times a day. Steroids are used due to anti-inflammatory and immunomodulatory property. If still not treated, intralesional steroid in case of single very painful ulcer which is not getting relieved by topical steroid, that is 10 to 20 mg of insoluble triamcinolone acetonide or 2 ml of dexamethasone is diluted with 0.5% saline or 2% lidocaine injection to lesion which solubilize gradually, injected directly into the lesion 2 times per week. Precaution to use intralesional steroid is use insulin injection syringe for intralesional injection to prevent the chances of deeper administration and give injection on the base transversely. This is the intralesional injection. For aphthous ulcer, steroid can be given intralesionally at the base of the ulcer, preferably with the insulin syringe. This is the case of major aphthous ulcer which is treated by intralesional injection. This is the major aphthous of dorsal surface of the tongue. This is the intralesional injection on the base at multiple sites, and lesion healed nearly 80% in a week time, and lesion completely healed with a little scarring in 14 days. This is the another case of major aphthous ulcer treated by intralesional injection. This is a major aphthous ulcer of left retrocommissure area. Intralesional injection at the base at multiple sites. Lesion healed nearly 60% in a week time, and lesion completely healed in a 14 days with a little scarring. Thank you.